I will present the results of an international study on hematopoietic stem cell transplantation from an HLA-identical sibling for sickle cell disease. As you know, sickle cell disease is one of the most common inherited hemoglobinopathies and is associated with many complications and early mortality. And to date, the only curative therapy is hematopoietic stem cell transplantation. However, indications for transplantation are still not well defined, and only a small fraction of eligible patients receive a transplantation. Several barriers, in fact, prevent its widespread application, such as a lack of a suitable donor, lack of information, and limited understanding on transplantation. Moreover, transplant encompasses a risk of early and late onset complication. In order to better understand the role of hematopoietic stem cell transplantation in patients with sickle cell disease, we designed a retrospective registry-based analysis, and we collected the data from the Eurocord-Monacord EBMT database and the CIBMTR. Children and adults who received an HLA-identical sibling transplant as first transplant before December 31st, 2013 were included in the study. The primary endpoint of the study was overall survival, while the secondary endpoints were engraftment, graft failure, event-free survival, and graft versus host disease. A questionnaire regarding patients and disease characteristics at diagnosis, transplant characteristics, and outcomes was sent out to the centers in February 2014. A total of 1,000 transplants from an HLA-identical sibling were collected from 88 centers in 23 countries between 1986 and 2013. 439 were referred to the CIBMTR and were transplanted in the US, while for the EBMT referring centers, 513 were European countries, mainly France, Belgium, Italy, and the UK. And for the EBMT referring countries non-European, Brazil was the most common. Most patients received the myeloablative conditioning regimen, 87%, while a reduced intensity conditioning regimen was given in 13%. In vivo T-cell depletion was given in 70% of the patients, ATG was given in 630 patients, while Campat was given in 76. The cumulative incidence of neutrophil engraftment was 98% after a median time of 19 days, and the cumulative incidence of platelet engraftment was 96% after a median of 25 days. The cumulative incidence of acute GVHD was 14.4%, and the cumulative incidence for chronic GVHD was 13.3%. The 3 years of event-free survival was 90% and was lower for peripheral blood in comparison to bone marrow and cord blood. The 3-year overall survival was 94% and was worse for peripheral blood as compared to bone marrow and cord blood. Also in multivariate analysis, we found out that younger age at transplant and the use of bone marrow and cord blood were independently associated with a better event-free survival and a better overall survival. Moreover, transplants that were after year 2000 were associated with a better overall survival. The risk of acute GVHD was higher with increasing age, and none of the variables tested were related with chronic GVHD. 7% of the patients had an autologous reconstitution, and 3% underwent to a second transplantation. Overall, 7% died, 6% after bone marrow, 21% after peripheral blood, and 1% after cord blood. And the causes of death were mainly transplant-related, such as infections, toxicity, and GVHD. In conclusion, this study on 1,000 patients transplanted with HLA-identical sibling donors show an excellent 3-year overall and event-free survival with a limited transplant-related toxicity despite the use of myeloablative conditioning regimen. This study shows that maybe an early referral to transplant for patients with severe sickle cell disease is warranted, as age is an independent factor for predictor for both event-free survival and overall survival. Moreover, transplants from peripheral blood are not recommended because we saw that there is a higher mortality with transplants with peripheral blood. Moreover, novel strategies are needed to lower graft failure and GVHD. What we can do to improve, we could perform a pre- and postnatal diagnosis in family as a risk, and we could suggest to perform an HLA typing in all the families when a patient is diagnosed with sickle cell disease. Moreover, we should transplant as soon as the criteria of severity are met, and ongoing are some strategies to increase the access on transplantation using alternative donors, and this study should increase the number of transplants in developed and emerging countries. Thank you.